I can lay no claim to that title for this talk. Actually, I saw it about a week ago and I thought, oh, achy flaky heart. Anyway, I've given it a different title. It makes it look less interesting. But I have to say, for me, this is serious. Like, it's deadly serious. And so if this feels like a serious talk in what's otherwise a bubbly and fun sort of conference, maybe I apologise for that. But this is a really big deal, rheumatic fever and rheumatic heart disease. It's a big deal certainly where I work in the north of Australia. It's a massive deal in Timor, and I want to show you some of the stuff around that. But I thought I'd start by asking, is it a big deal to you? I mean, there's quite a few of you in the room, you're interested, but who here has seen a case of acute rheumatic fever? So I reckon half, maybe. And rheumatic heart disease, are there more who've seen rheumatic heart disease and acute rheumatic fever? A few more. I mean, this is something that's part of my everyday reality, but here's the reason why half of you haven't seen it. This is a graph that comes not from Australia, but from Denmark and the US, and it gives you a bit of an idea of what's happened to acute rheumatic fever and rheumatic heart disease in most of the developed world. And it's the reason why rheumatic heart disease has kind of dropped off the curriculum in many of the medical schools in the developed world. Even in Australia, it doesn't get talked about a whole lot because it appears to be disappearing. But this is my reality in the Northern Territory, and I know this graph only goes to 2011, but if anything, what we've seen over the last 6-7 years is a continuation of this bubbling along, if anything, maybe a slight increase. And so we continue to see these acute rheumatic fever presentations in the Northern Territory. It's an ongoing part of our work. It's part of the makeup of our paediatric ward. There would be a very rare occasion that we would have our paediatric ward that didn't have somebody with acute carditis admitted because of that. And the impact of rheumatic heart disease in Australia is severe. And I can look at this picture and you can look at it and say, well, that's a child going to cardiac surgery. I don't know this child. A lot of the pictures of the kids on here I do know. But I look and I think of the ones that I do know. I think of the one, where's Laura Cordy? She must be in here somewhere. We've been at the end of a bed together trying to resuscitate a girl who tried so hard to die on us in the Northern Territory at 14 years of age with severe carditis and then anyway, long story, anaphylaxis afterwards. It was a really difficult situation where you think this is a 14-year-old girl in the prime of her life. She survived that, and I'm pleased to say that the last time a child under the age of 18 died as a direct result of rheumatic heart disease in the Northern Territory was some 5 years or so ago, but that's not very long ago. And I'm talking about an everyday reality where we still see children come in with severe carditis, with third-degree heart block, with massive cardiomegaly and dyspnea and requiring heart failure medications to tide them over until they get to surgery. And so we're kind of on the brink a lot of the time, but this is the reality in terms of the impact, is that we see children who require cardiac surgery from very young ages, some of them 5, 6, 7 years of age having their first open heart surgery, some of them going through to have repeated cardiac surgeries. And by the time they're 13, 14 years of age, they've had 5, 6, 7 open heart surgeries to repair their valve again and again and again and ultimately end up with a valve replacement. And so this impact in Australia is very real and it's very much a part of the work we do. The impact of rheumatic heart disease in Timor is truly devastating, and it's, I guess, a whole nother level. And this is a girl whose life will be short. She was 11 years old when she was diagnosed with rheumatic heart disease and had severe rheumatic heart disease at the time that she presented. She also had a diagnosis of tuberculosis and was treated for both, and her heart failure has been managed, and she was sort of taken through that initial phase of being incredibly unwell. And this is a photo of her when she was looking unwell. I've got other photos of her when she was looking magnificent. But she had an echocardiogram earlier this year from a visiting cardiology service from Australia in the hope that her mitral stenosis would be amenable to surgery in Australia, and it isn't because of the severe pulmonary hypertension that she's developed. And this young girl, the age of my second child, is unlikely to live beyond the age of 12, 13, 14 years of age. And time again, we see these kids who come in heart failure, and we manage them for their heart failure with nowhere else to go. The impact of rheumatic heart disease in Timor-Leste for most isn't an end point of repeated cardiac surgery by the time they're 18. For the children with severe rheumatic heart disease in a place like Timor-Leste, the impact of rheumatic heart disease is a tragic death in the prime of their life, in their teen years. And so it's not a light-hearted talk. It's a terrible thing, and it's a terrible thing that, as I said, I have to deal with on a daily basis, and it's part of my thinking in terms of the work I'm doing in Timor. It's certainly part of my thinking in the Northern Territory. And you think, what a tragedy that these kids in Timor don't get access to cardiac surgery. And it is a tragedy. And the people who are working hard to get access to cardiac surgery for children in Timor-Leste are doing a marvellous thing and have been able to save lives here and there and make a really big difference. But I want to say to you, and this is going to be the focus of my talk, is to move away from this cardiac surgery idea. It's not the solution. This is a young fellow from the Northern Territory who's happy for his photo to be shown. In fact, he stars in a brilliant movie called Take Heart that you should see if you haven't had a chance to see it already. His name's Liddy Wu, and he's had multiple cardiac surgeries. He had a mitral valve replacement at the age of 13 and is going to be on warfarin for the rest of his life. And when I say for the rest of his life, this data from a study that Jonathan Karapetis published in 1999 demonstrates that the chances of him living beyond 30 are actually very small. So the median life expectancy following a valve replacement for rheumatic heart disease in Australia, this is Australian data looking at the north of Australia, the median life expectancy is between 10 to 15 years post-op. And this kid had his mitral valve replacement at the age of 13. So if that's not sobering, I don't really know what is, but it does say to me that cardiac surgery can't be the solution. And many of you will have seen a graph like this that gives a bit of an idea of some of the other approaches, some of the things that can be done to get at this disease before it gets to the point of needing open heart surgery for a young kid like Liddy Wu. And so we've heard already this afternoon a little bit about scabies and about impetigo. And this is a big focus that I'll talk about in a moment about primary prevention, but there's also this opportunity to cut this off at the core and to stop this from happening, to stop these group A strep infections from happening that then lead to acute rheumatic fever. And then I'll talk a little bit about secondary prevention as well. But to start with, and very briefly, a picture from that Take Heart movie that I mentioned. This is a picture of one of the houses that Liddy Wu has lived in over the last number of years. This is a house that's in Darwin. It's not actually in remote Northern Territory. It's in one of the suburbs of Darwin. It's a house with 2 bedrooms that will sometimes house up to 12, 15, even 18 people. And these are the sort of living conditions that people in our country, in our society, are living in. And is it any wonder that they continue to get recurrent scabies and recurrent group A strep infections? And people ask me, why don't we see acute rheumatic fever and rheumatic heart disease in non-Indigenous people in Australia, in non-immigrant people in Australia? Can't anybody get group A strep infections? And absolutely they can. I've got 4 kids, and I'm sure at least one of them has had group A strep in the last little while. They live in the Northern Territory. But they might get a group A strep infection, but they're not going to then be re-exposed again 2 weeks to group A strep again and again and again and again, and every day going back to this same soup of group A strep. Primary prevention is something that we have not done well in this country. We haven't done a good job of treating impetigo. And Mel, when she presented that data from the north of WA that shows that even children who are being admitted to hospital and their impetigo is completely missed because we're too worried about other things and the sores seem normal to us. And sore throat in the Northern Territory is not a common presentation. Now, is that because kids don't get group A strep sore throats, or is it because they don't see the value in turning up to a clinic to get treated? In New Zealand, over the last number of years, there's been a real focus on the primary prevention of acute rheumatic fever and rheumatic heart disease. And by primary prevention, I mean getting in there, treating the group A strep infection before this immune-mediated acute rheumatic fever develops. And so they've had a focus that's largely been centred around schools, and they've developed school-based sore throat clinics. It's a great invention if you're a school kid who wants to get out of class. Basically, you stick up your hand and say, "Miss, my throat's a bit sore," and you get out of class for a bit. You go off to see the school nurse. They do a throat swab. They've got an excellent microbiology service, and if the child has group A strep in their throat and they're presented with a sore throat during school, they get put onto 10 days of antibiotics. And this is starting to have a real impact. And the papers are only just starting to come out, and there will be more over the next year. This was a very early one published in PIDJ, just a letter to the Paediatric Infectious Diseases Journal, where the designers of this program, basically a public health intervention, are starting to let us know that this is having a real impact. So these graphs follow years, and they follow the incidence, if you like, of acute rheumatic fever notifications. And you can see that particularly in the Maori and Pacific Islander populations in the North Island of New Zealand, they see high rates of acute rheumatic fever, similar to what we've been seeing in the north of Australia. And these rates, as you go through the year, January through to December, every year they sort of peak up at around 40 cases. Now, in 2015, and you can see the trend starting even from 2014 after this program was introduced in 2013. You see that the numbers are far less, and this, as I said, is some early data that's starting to emerge with more to come, but a really strong case emerging out of New Zealand to say, if you get this primary prevention right, you can make a significant dent in the incidence of acute rheumatic fever. Treat the children for their group A strep infections and stop them from progressing to get acute rheumatic fever. Something that we have to listen to here in Australia. Our focus has tended to be on secondary prevention, and to describe secondary prevention to you, I've got this graph that gives you an idea of some of the findings that you see with acute rheumatic fever. Now, many of you put your hand up to say that you've seen cases of acute rheumatic fever, and we get used to seeing children present with joint symptoms, with arthralgia, with arthritis, and thinking, oh, could this be rheumatic fever? And we obviously worry about the carditis. In that episode of acute rheumatic fever, this is the thing that has the big impact. The joints will get better. The fever will get better. The nodules, even if you've got them, they will disappear with time. But it's the carditis that causes the significant and long-term damage. And the first episode of acute rheumatic fever that you get, your risk of having carditis in that first episode, it's around about 60%. And so a significant proportion of children, so typically between the age of 5 to 15, who present with their first episode of acute rheumatic fever, will have some of the other manifestations of acute rheumatic fever, but their heart's all right. And it's a great thing to be able to tell a kid and say, look, your heart's good, it's healthy, and we want to keep it healthy. And the opportunity that this gives us then in that child to focus down and say, we are going to stop you from having acute rheumatic fever. We don't want to see you back in this hospital again. We don't want you to come back in, because the next time you come with acute rheumatic fever, your risk of having carditis is up in the 90s. And so the risk of having having carditis with a subsequent episode of acute rheumatic fever is up over 90%. And so it's in these children that you see the progression of rheumatic heart disease, children who come in with recurrent acute rheumatic fever. Now, this provides for us a real opportunity to have a significant impact on a cohort who are at significant risk of progression of rheumatic heart disease. And even in children with established rheumatic heart disease, every subsequent episode of acute rheumatic fever, even a kid like Lydia who's had cardiac surgery before, he gets acute rheumatic fever again, and there's more valvulitis, and the tissue around his valve replacement starts to break down and he ends up in trouble. And so for these kids, getting them onto some sort of a regimen to stop them from getting further acute rheumatic fever is hugely important and a big focus. And this is how we do it. I don't know if that looks nasty enough. It does look large on the screen there. I promise you it looks large in real life. Maybe not as large as that, but I think some of the kids, like their eyes get big, maybe as big as that picture, because you come at them with this awful needle. Has anyone had a bicillin shot in the bum? So I've got, no, I don't really have anyone to give you one. That would have been good, actually, if we could have brought somebody to administer them. I remember the first time, so it's funny that I would remember this about my wife, but I remember the first time my wife gave a dose of benzathine penicillin. And the reason I remember it is because I prescribed it, she had to give it, and she didn't talk to me for about 2 days. She said at the end of that, don't ever make me give that medication to another child ever again. And then we moved to the Northern Territory, and she has to do it all the time. But it's truly awful. I mean, this is a really awful thing to have to do. And these children who go on to this regimen of secondary prophylaxis as secondary prevention against acute rheumatic fever and rheumatic heart disease, they're set up for getting this benzathine penicillin injection in the bum every 3 to 4 weeks. And the children with mild rheumatic heart disease will get it for at least 10 years or until they're 21. Those with moderate disease here in Australia, our guidelines recommend having it until they're 35 years of age. And those with severe disease who have required cardiac surgery are on it lifelong, many of them. And so you're talking about hundreds, literally hundreds of these injections over a lifetime for these children. And it's a terrifying prospect. This is a kid who I know well. I mean, it's not the whole kid, obviously. It's just a MRI image. And this child, the first time I was asked to see him was as an ID consult. Can you come and see this kid? He's come in with left hip pain, and he's come in with a bit of a limp, and he's got a fever, and he's had rheumatic heart disease in the past, but we think he might have septic arthritis. And so we've done an MRI. Very efficient. So easy to get an MRI in Darwin, actually. Are there any radiologists in here from Brisbane? No, they're all hiding. Anyway, I promise you it's easier in Darwin than it is at Lady Salento. This kid had had an MRI by the time I came to see him, and you could barely see the effusion on his left hip from his acute rheumatic fever. What you could see was this horrendous chemical myositis from his benzathine penicillin in his right butt cheek. And this boy had a progression of his rheumatic heart disease in that admission, and he's had 3 subsequent episodes of acute rheumatic fever. And on every single occasion, his rheumatic heart disease has progressed. And this boy is now 9 years of age, and he is going to have cardiac surgery before he's 10 or 11. There's almost no doubt about that for me. And the reason why he keeps having recurrent acute rheumatic fever, he runs away from home every month when this penicillin shot is due. And is it any wonder? Like his bum, like he couldn't walk for 3 days. His left hip felt so much better, but he's limping because of his right. It really is a horrific treatment for this. And so, I mean, I've got this slide to tell you it's horrific. I hope that makes you feel a little bit bad. It makes me feel a little bit bad. You think of all the things that we invest in terms of trying to find better solutions. This is one that desperately needs it. There is work being done to find a better preparation. Basically, we're using a product that's been around for 50 years with no innovation to date. And it's time, it really is time to come up with a better solution for these kids, some way of being able to deliver penicillin that doesn't require them to go through these painful injections on a 3 to 4 weekly basis. But secondary prevention, for all of its problems, it works. Like, it really works. I mean, if you give penicillin every 3 weeks to these children, they don't get group A strep infections. They don't get sore throat. They might get scabies, but even they can scratch it all they like and they don't get impetigo because they're being bathed in penicillin and the group A strep doesn't get in. And so their strep titers stay low, their joints stay good, their carditis doesn't progress. In fact, some of them, their rheumatic heart disease will regress even to some extent. And so secondary prevention is an incredibly effective measure if you can do it right. But if you can't do it right, they come in like that young fellow with the hip. And if you don't find them in the first place, there's no way they can get onto it. And so I want to talk a little bit about what it means to make that diagnosis of acute rheumatic fever, to make the diagnosis of rheumatic heart disease, to find the children who will benefit from this intervention that can literally save their life. And so first of all, I just want to talk about recognising acute rheumatic fever. And I wonder, is there anyone who has seen this before, or can tell me what you think that it is? Yeah, go for it. Yell it out. Yeah, so it's erythema marginatum. And I feel a little bit bad because I've seen this kid didn't take any photos, and I've having to get a dodgy one off, like just Googling for a photo of erythema marginatum. But there's a child who's been looked after in Royal Darwin Hospital this year who presented, we don't see this very often, this is one of the major manifestations of acute rheumatic fever, but it's uncommon, it's particularly uncommon in a setting where acute rheumatic fever is recognised early, diagnosed early, and treated. But for this kid, that actually had this coming and going rash, and it typically is a coming and going sort of rash. It sort of flares up, goes down, flares up, goes down. And he'd had this over a couple of month period until he presented, and he had some arthralgias during that time as well, and he presented with significant carditis and has moderate to severe rheumatic heart disease. Now, the tragedy of this case is that this child had presented to a hospital in Australia, not in the Northern Territory, some 2 months prior to the onset of the rash, with a polyarthritis at that time. He'd had a polyarthralgia really, but with one swollen knee, and had raised streptococcal titers at the time, and was discharged without a diagnosis of acute rheumatic fever. Now, this is not an isolated case, and me saying it's not in the Northern Territory isn't to say that we get these things right in the Northern Territory. I could easily have presented a number of cases in the Northern Territory that have come back to us with significant and severe rheumatic heart disease, having had a misdiagnosis of their first episode of acute rheumatic fever, a missed opportunity to put them onto secondary prophylaxis. And so recognising acute rheumatic fever, I want to say to you, and this is a take-home message, that this is important wherever you live in this country, and there are people who are at high risk, and so the Australian guidelines have been separated out since 2006 to look at high-risk and low-risk populations to be able to put in people's minds this idea that we have people in our population, Indigenous, Maori, Pacific Islander, other immigrant populations who are at high risk of acute rheumatic fever. And thinking of acute rheumatic fever and making the diagnosis is so important. And this is a table that outlines some of the changes that have happened in the Jones criteria over time. And Australia really has been ahead of the curve in terms of trying to have some tight definitions that make sense in the current day and age, that make sense of the fact that we can get echocardiograms to diagnose subclinical carditis. And the American Heart Association has followed suit with a publication in 2015 with revised Jones criteria that identify the need to have criteria that apply to high risk as well as low risk populations. Anyway, you're not going to take in those tables. If you can take this in, please do. This is a sort of conference where everyone's supposed to have their phones out, isn't it? So get your phone out and download this app if you don't have it already. You can get it whether your phone's iPhone or Android or whatever it is. And so this is the Rheumatic Heart Disease Australia ARF and RHD guideline app. It's a very good app in terms of some useful information with the guidelines, but probably the best feature of it is this diagnostic calculator that will allow you just to sort of work through, and you get a kid who comes in with a polyarthritis or a polyarthralgia, and you plug things in as you go, and it'll spit out a diagnosis for you at the end. It's brilliant. I heard someone say recently, if you're not used to diagnosing acute rheumatic fever, use this. I think even if you are, get the app. It's definitely worth having, and will help to keep you thinking about it. One of the problems with focusing on detecting acute rheumatic fever, though, is that many children don't present with acute rheumatic fever. Many children don't present with this self-limiting polyarthralgia and fever that kind of gets better on its own anyway. And so there has been a lot of work done in recent times to look at screening for rheumatic heart disease, to diagnose rheumatic heart disease in those already with established rheumatic heart disease as a way of establishing them onto penicillin as secondary prophylaxis and preventing further progression. And this is some work that's been done by Kath Roberts, one of the paediatricians up in Darwin, who did her PhD looking at echocardiography screening within schools across Northern Australia. And what she found is actually quite striking. She found some of the highest documented rates of rheumatic heart disease in the world, in the high-risk populations, in Indigenous communities, particularly in the top end of the Northern Territory, with 15 per thousand having definite rheumatic heart disease at the time of screening. And importantly, half of those cases that were diagnosed during these echocardiography screening events were previously undetected cases. And so these are undetected cases living in our communities, kids with established rheumatic heart disease who don't yet have a diagnosis. And so what she's demonstrating here, and it's been followed up with some cost-effectiveness studies, to say this is one way that we could find some of these undetected cases, start children on penicillin and prevent progression of rheumatic heart disease, and have an impact on reducing the risk of progressing to cardiac surgery and even early death. We look to do a similar thing in Timor-Leste, and I want to take you very briefly through the results of this just in the few minutes that are remaining. We wanted to look at an abbreviated protocol for echo screening, thinking, look, this is a small country, but still it's a country with 1.5 million people and half of them are children. If we wanted to scale this up, is there a way that we could do it that would be not only cost-effective but also time-effective, and to see if we could establish a rheumatic heart disease register to deliver penicillin effectively in Timor. And what we found were that the rates of definite rheumatic heart disease and borderline rheumatic heart disease were as high or even higher than what we find in our Indigenous communities in Northern Australia. And importantly, of 48 cases that we found, we screened 1,400 children in a crazy 5 days in Dili and also up in the mountains in Timor. And we found 48 cases of rheumatic heart disease, and all but one of them had never had a diagnosis of acute rheumatic fever or rheumatic heart disease. And so what we're describing really is a massive burden of latent rheumatic heart disease, of rheumatic heart disease that's gone undiagnosed in this country. Probably the most satisfying of the whole thing for me was finding cases that were mild or moderate, and all of these cases were either mild or moderate, and it's the first time literally in Timor that I've seen a child with mild or moderate rheumatic heart disease, because typically by the time they present to a health service, they're presenting with dyspnea and heart failure. And so if you look at the burden of rheumatic heart disease in Timor-Leste, it's the one that sort of scores the very left-hand side of this graph, obviously with wide confidence intervals, but an indication to you that the burden of rheumatic heart disease in Timor, as we're expecting to find, is incredibly high. Now, what do you do with information like this? I mean, in some ways you can scratch your head and not really know where to start, which is maybe a bit of a theme for Timor in some ways. It's a difficult place with so many health challenges, but for me this is one of the big ones, and it certainly has a massive impact on the work that I do there. And if you're going to identify cases of rheumatic heart disease, how do you actually manage this? How do you deliver penicillin in a place like Timor? How do you engage the community and educate them and make sure that you're able to achieve this? And so we want to answer these questions, and we want to ask some more questions about the utility of screening, but also look at ways of empowering local health workers to be able to do the screening themselves. And we're planning towards some studies that are funded through a Hot North program, which is a federal government-funded research program operating throughout the north of Australia and engaging with our regional partners. And we're going to do some more work to identify more cases and hopefully do an effective job of preventing progression of rheumatic heart disease in these children. And what it's relied on actually, more than anything, is this guy on the right of the picture, but taking a nurse with him and into these communities, visiting homes and visiting schools and delivering penicillin. And this fellow Inari, I wish he could be here today to introduce you to him. He's spent a bit of time in Australia doing some training and education with Rheumatic Heart Disease Australia and with our nurses up in the Northern Territory. And I have to say, he's more effective at delivering penicillin than anybody that I know in Australia. And of the children who were diagnosed with rheumatic heart disease in that study we did in October last year, now 12 months down the track, more than 90% of them are getting around 90% of the injections that they need, which is a terrific outcome and better than the outcomes that we see here in Australia. And so it is possible with community engagement with families and education for the community, and it's work that is still more to be done. Thanks very much.